Thank you very much for your introduction, Dr. Berciano, and good evening to everyone. As you know, CMT is the most common form of hereditary neuropathy with a prevalence ratio in Cantabria of 28 per 100,000 people, and in Spain it's estimated there are around 12,000 CMT patients. CMT1A is the most common form of CMT, reaching a percentage of 55% of all CMT types and 70% of all CMT1 forms. It is associated with a large duplication in the short arm of the chromosome 17 containing the PMP22 gene. The nerve conduction velocities are uniformly decreased around 15 to 30 meters per second in most of the patients. In previous studies, the following issues have been established. First, the gene penetrance is complete the first decade of life, and muscle atrophy is not correlated with the nerve conduction velocities reduction, but with reduced motor potential amplitude, what indicates that it depends on a secondary axonopathy, here length dependent. Nevertheless, the medium-term progression is a controversial question, whereas there are authors that haven't observed significant differences in comparison to controls, there are others that have found that the disease progression can be detected by CMT-NS scale. On previous MRI studies, we have observed that muscle fatty infiltration pattern varies during the clinical course. To date, there have been several cross-sectional studies evaluating MRI findings in neuromuscular diseases, including CMT, but there remains to carry out a longitudinal study analyzing a possible correlation between muscular MRI and clinical electrophysiological examination. Our initial objectives were, first of all, to establish the CMT1A evolution during a 2-year period correlating clinical modifications, including dynamometry, to electrophysiological and lower limb muscle MRI findings. Secondly, implementing CMT-NS and FDS scales, which allow comparative analysis with recent studies of the disease. And finally, looking for parameters which predict the clinical progression of the disease through a variable called increase in CMT-NS that we'll see deeper in the following slides. The study was designed to carry out a longitudinal follow-up during a 2-year period, including 14 CMT1A patients who were assessed twice at baseline and 2 years later, and 14 age and sex matched controls who were assessed just once with the same protocol applied in patients. Every participant must sign an informed consent, and the study was approved by Clinical Research Ethics Committee of Cantabria. The selection of patients of controls were conducted at neurology clinics of University Hospital Marqués de Valdecilla. We collected affiliation data, family and personal history, including, among others, physical surgery and physiotherapy. The inclusion criteria were first the CMT1A clinical diagnosis, the genetic confirmation that every participant signed an informed consent, and the non-compliance of any exclusion criteria, including other causes of neuropathy, other neurological or major comorbidities, and foot surgery 6 months before or plain before the end of the study. Neurological examination included the following items: the localization and evaluation of muscular atrophy in upper and lower limbs, the foot morphology, and the evaluation of the muscle power using Medical Research Council scale. We assessed 12 muscles in upper limbs and 15 in lower limbs. In dynamometry, here handheld dynamometry CTEC, we included the following parameters: in upper limbs, the 3-point grip, the fist grip, and the pinch grip, and in lower limbs, the foot dorsiflexion and the foot plantar flexion of the ankle. We also examined tendon reflexes, sensitivity, and other neurological symptoms, for example, tremor. And we performed several tests. The first one, the lunge test, measuring ankle flexibility, the 10-mark walking test, and the 9-P-hole test. In order to determine the CMT1A disability, we administered the CMT neuropathy score in its first version from side colleagues and the 9-point functional disability scale to determine the walking disability. All electrophysiological studies were performed by the same examiner with the same equipment and using standard methods on peripheral nerve conduction and electromyogram studies. All lower limb MRI studies were performed by the same examiner using a 1.5 Tesla clinical scanner, and the applied protocols were in calf and thighs, T1 and T2 fat suppression on both axial and coronal planes, and in feet, T1 on long and short axis of the foot. We systematically looked for signal intensity alterations, evaluating the appearance of fat infiltration, muscle edema, and abnormal contrast enhancement. All statistical analyses were performed using SPSS program version 19.0. Initially, we performed a univariate analysis comparing the patient's group modifications on serial examination, and in order to evaluate progression, we constructed a quantitative variable called increase in CMTNS, which consists of the second total score minus the first. And finally, we perform a multiple linear regression model, including all the possible predictors associated to increase in CMTNS with p-values lower than 0.2 in the univariate analysis. 9 patients were women and 5 men, and the patient's mean age at the first visit was 31.6 years with a range of 12 to 51. And the mean age of onset in the 11 symptomatic patients was 5.5 years with a range of 1 to 38. Only one patient had undergone Pescavo surgery several years before. At baseline, all patients show Pescavus, and EDV atrophy was an invariable feature in all 14 patients, excepting for 2 adolescents, and after 2 years of follow-up, the atrophy of this muscle was present in all patients, confirming that on the one hand, EDV severe atrophy doesn't occur until the second decade of life, and that together with Pescavus, they are the initial signs of disease etiology. 6 patients showed peroneal atrophy without progression or the no appearance in the rest of the patients, and in upper limbs, 2 cases show intrinsic musculature atrophy of the hands, and after 2 years of monitoring, the atrophy appeared in 3 more, and especially in interossei muscles. Achilles tendon reflexes were absent in all patients at baseline, and only 1 patient showed patellar reflexes, but this reflex disappeared on the second evaluation. However, the differences were not significant. In the current study, there was a good correlation between MRC muscle testing and dynamometry for the evaluation of the strength. And at baseline, 9 patients showed peroneal weakness, but only 3 after 2 years of monitoring, so a slightly pronounced worsening. The greatest weakening occurred in the anterior lateral compartment of the lower legs, affecting the extensor digitorum longus in 7 patients, tibialis anterior and peroneal in 3 patients, and extensor hallucis longus in 2. We observed mild proximal muscle impairment in 2 cases, in 1 case in both iliopsoas and in the other one in the dominant knee flexors. Therefore, instead of being a significant marker of disease progression, leg weakness could be a manifestation involving just a reduced subset on CMT1A patients, and it is noteworthy to point out that maybe the decline of strength is secondary to, at least partially, a process of normal aging. In upper limbs, the decline of strength was mild, never below 4/5 on MRC, and limited to the stone musculature in the upper limbs, muscle of the hands. And in dynamometry, the 3-point grip was the most affected parameter, but no significant differences were observed. Leaving foot plantar flexion aside, which was normal in all patients, we observed on dynamometry a decline of strength, more marked on foot dorsiflexion and 3-point grip, but no significant differences were observed, and only the dominant 3-point grip showed a trend to significance. In 5 patients, hypoparesthesia increased significantly to iliac crest level, and this is a remarkable fact because reduction of somatosensorial sensitivity due to the loss of large myelinizated fibers is closely associated with postural instability in CIIEN patients. The lunge test is extremely useful for evaluation of ankle flexibility loss. The elasticity is considered to be restricted when the distance big toe to wall is lower than 9-10 centimeters, and the angle between the vertical and the tibia or the Achilles tendon is lower than 35-38 grades, as you can see in this figure. On the right side, one of our patients, and on the left side, one sex and age match control in whom the test was completely normal. We observed that the test was abnormal in all patients at baseline, but there was a decrease of the elasticity even at the second evaluation, whereas in controls the test was completely normal. We propose to use this test to evaluate rehabilitation treatment and or orthosis, especially in adolescents in whom foot function must be preserved in the future. The 10-meter walking test was slightly prolonged in patients in comparison to controls with a mean of 6.5 seconds versus 5.7. In spite of this, the difference between the patients group were not significant, and this is consistent with the observed FDS normality. However, we found significant differences on 9-per-hole test on both dominant and non-dominant sides, and we propose or suggest this test to evaluate disability and disease progression in the upper limbs in future clinical trials. Regarding to the FDS scale, the patients scored at baseline between 0 points when the ambulation was normal to 3 points where there was a walking difficulty but still possible and aided. And during follow-up, only one patient progressed from 0 point to 1 due to the appearance of cramps and fatigue. We observe a mild, though significant increase on the CIIEN's final score with a total median of 8 points with a range of 5 to 12. That increased to 11 points with a range of 5 to 17, which were correlated with vibration in lower legs, strength in the arms, and ulnar snap amplitude. Curiously, none of the lower limb parameters significantly influenced this score, and this is a fact in good correlation with the absence of worsening in the FDS. The increase in the score mean was 2.6 points with a range of 0 to 8. Confirming previous electrophysiological studies, we observed marked and diffuse slowing of the nerve conduction velocities, but the median values remain stable during monitoring. As a whole, the CMAP amplitudes of the examined nerves did not show significant reduction, but consider the relevance of the tibialis anterior power in the development on CMT1A disability. We specifically looked for the tibialis anterior CMAP amplitude, but after stimulating the peroneal nerve at popliteal fossa, but only one patient showed a reduction more than 50% of the amplitude, with neither change on the strength manual or by dynamometry nor on cuff MRI. Another recent longitudinal study, including 27 patients, Comiathi et colleagues found a mean reduction of the tibial is anterior amplitude of 0.14 millivolts per year, with a strong inverse correlation between this amplitude and leg strength assessed by dynamometry. So therefore, the discrepancy between our study and this one calls for future clinical electrophysiological evaluation. Our initial MRI study corroborates previous cross-sectional imaging investigation, demonstrating a constant and predominantly distal fat infiltration, with the foot muscles being more densely infiltrated than the calf muscles and the calf muscles more than the thigh muscles. However, this pattern did not change during follow-up. To the best of our knowledge, there are no other longitudinal MRI studies to establish any comparison. This figure is a T1, an axial T1 weighted imaging through the middle third of the lower leg. And you can see one of our patients with fat infiltration in the right peroneus longus. This fat infiltration remained unchanged after 2 years of follow-up. During monitoring, only one patient suffered from a progression, subclinical progression of fat infiltration in both gastrocnemius medialis. From not being noticeable at the first evaluation, it went on to be a grade 1 at the second evaluation. And other 2 cases, they suffer from a subtle and subclinical progression of the fat infiltration, in one of the cases in both peronei longus and soleus, and the other one on both gastrocnemius medialis. As you can see in the following picture, it's a coronal plane. So the fat infiltration, this is the first examination. The second one, the fat infiltration in the gastrocnemius medialis remained below the 25 of the volume of the muscle, and therefore in a grade 1. What are sensitive sequences here to fat suppression? Have the patients exhibited edema in calf muscles, excepting for the flexor hallucis longus and the flexor digitorum longus muscles. We couldn't find edema areas in feet nor thighs. During follow-up, such edema areas could remain either unchanged or reduced, but with a correlation with weakness or appearance of accentuated fat infiltration in the muscle bellies. This is a T2 fat suppression weighted imaging through the middle third of the lower legs. You can see on the left leg edema in all the compartments of the calf, especially involving the gastrocnemius medialis, the soleus, the gastrocnemius lateralis, and the tibialis posterior, that remain unchanged after 2 years of follow-up. In previous cross-sectional MRI studies, it was reported that edema could be in around 1/3 muscles showing fat infiltration. And given that edema causes subacute denervation, it was proposed it may be due to superimposed nerve inflammation on the genetic condition. However, the current study indicates that maybe edema is just a mere finding without correlation with clinical progression. So this issue could be clarified in the future with other more sensitive techniques, for example, MRI, magnetization, transferation. In order to evaluate independently of the possible predictors associated with increasing CMTNS, we constructed a multiple linear regression model, including all the factors with p-values with less than 0.2 in the univariate analysis, which were hand intrinsic muscle atrophy, EDB muscle atrophy, peroneal musculature atrophy, median nerve sensory condition velocity slowing, tibial nerve distal motor latency prolongation, ulnar snap reduction, diminution of vibration sense, lower legs, gastrocnemius lateralis fat infiltration, and gastrocnemius medialis edema, but none of them were significantly associated to CMTNS increase. Although our primary outcome was evaluate modifications in lower legs, given the results in upper legs, such as the appearance of distal muscle atrophy during monitoring, though not significant, the trend to significant of the 3-point grip on dominant side, and the significant results of the 9-hole test, we propose the upper limb assessment in future clinical trials in order to evaluate the disease progression. One of the justifications for these results could be the slow natural history of the disease and the requirement to carry out longer longitudinal studies with larger sample size. One of the limitations of our MRI study is that we used conventional T1 images in order to evaluate fat infiltration in a semi-quantitative manner through the Gattelier's classification, and currently there are other more sensitive techniques, for example, the 3-point Dixon that is currently ongoing. So finally, we conclude that in the 2-year period of monitoring, CNT1A patients showed minimal progression, and that there was good concordance between clinical, electrophysiological, and imaging findings. Our results call for caution in therapeutic trials scheduled for up to 2 years. So, thank you very much.